So again, we're looking at advanced care planning. Today's objectives are to describe how we've looked at end-of-life care in face of the pandemic. We'd like to look at special circumstances that relate to advanced care planning, and then also to talk about and identify tools that help structure advanced care planning. And then finally, just a very brief introduction on how to determine decision-making capacity as mentioned in our poll questions. Okay, next slide, please. So, I just wanted to mention how long does previous COVID infection protect you from reinfection? So this is the study, from that original question. Again, it was published in the British Medical Journal here just a couple of weeks ago. There was 20,000 healthcare workers, the vast majority who were women, who were monitored, and they found that of those that were infected, the distance or time between the first and then their reinfection was 160 days. So about 4 to 6 months was the range, and that again, 1/3 of the individuals who were reinfected had some types of symptoms, but typically those symptoms were milder than what they had experienced with the first infection. So the conclusion was that there was up to 86% protection from a second infection for up to 6 months, which quite honestly is not much to write home about. Okay, next slide, please. So we want to hone in on advanced care planning. And I think really, as for all of us, and myself included, I mean, honest to gosh, I only got my advanced care planning done last year. And, here I am, a geriatrician advocating for this. So, I'm like a turtle on this one. So it's always something that can be somewhat uncomfortable and stressful for older adults, their family members, healthcare professionals. So we just have to be mindful of that fact, and that a lot of times, and this is really an important point, there's been multiple studies that show that older adults and family members will commonly overestimate remaining life expectancy, and they really are very optimistic. And so there was a study done with cancer patients, and they asked how long, and these were terminal cancer patients, and the survey asked, how long do you think you'll live with your cancer? And uniformly, people said 4 to 6 years, when in fact their prognosis was 6 months to 1 year. So there's just a vast difference between what we are hoping for and what reality really dictates. So we sometimes have to be mindful of that. And this is particularly true in chronic conditions such as heart failure. So somebody that has a really advanced heart failure, let's say they have a systolic ejection fraction of 15 or 20%, that individual is likely fits a category of a 6 to 12 month lifespan, remaining life expectancy. And again, if you ask the family members, they may say, oh, he's got a couple of years, maybe 3 or 4 years to live. So again, there's this distortion between reality and the perception of or the hopes of the individual that we need to recognize. Okay, next slide, please. So the problem with COVID is that it kind of has jumped on us. There's complications of the infection that can be either sudden or slowly progressive. And so it really puts us in a position where if you don't have advanced care planning and you get the infection with, particularly in the 80 and older population, there may not be a lot of time to really get this reconciled. So the point being is that in older adults, of those patients that go on with COVID and pass away, 1/3 of them will have a sudden course, whereas the other 2/3 will have a more indolent or progressive course. So part of the process that we would highly encourage is to proactively assess remaining life expectancy. We in geriatric medicine use the e-prognosis referral, so this is sponsored by the University of California at San Francisco and their geriatrics program. And they have different disease states, and as well as COVID. They have a COVID page too that gives you an estimate of remaining life expectancy. And I just want to point out that there's two concepts. There's absolute life expectancy, and then there's quality of life expectancy. And usually there's about a 2 to 3 year distance between those two concepts. So somebody might live to be 88 years of age, but they will have endured 3 years prior to that of a slow, debilitating process. So if somebody has several debilities or impairments of activities of daily living, they, by definition, are in that window of a 2 to 3 year period that will likely occur before they pass away. And then also just recognizing that last point up there or down here is that there's 20% mortality with COVID in 80-year-olds. Next slide, please. So we always want to be mindful of trying to align our treatment, whatever our interventions are, with patient preferences. And just to acknowledge the fact that this is a dynamic process, that the preferences often change. There was a Johns Hopkins study that found that 90% of patients that went into the emergency room who were able to speak on their own changed their advanced care directives right on the spot. They said, yeah, of course, I'm here, treat me. Whereas the people that were not able to speak and were either in a coma or stupor, they had their advanced care wishes honored. So it's just one of these things that, we have to be mindful that people do change their mind. However, from our point of view as providers, we need to sort of be the messenger and to know when comfort care is really the only thing that you can do. I mean, sometimes people do cross the bridge where there is no return, and there's nothing medically that can be done to reverse their chronic illnesses, their dementia, and so that a COVID infection may just be their passage for the inevitable. So I think that's an important point of reconciliation that we need to have with patients and family members. Next slide, please. So the Institute for Healthcare Improvement, created this model or this paradigm, which I think is helpful from a geriatrics point of view, to just think about care goals. And so basically there are 3 different kinds of categories. I always think in terms of 2. I said either we're going to go full steam ahead with prolonging life and do pull all the stops, or we're going to go in comfort care. But I think there also are that middle of the road group where they're moving along with some disabilities, but you still have hope that you can maintain some level of functionality. So that would be a third group. And we just look at that on the left there with prolonging life. The focus of care is whatever we can do to make the person live longer. So that's the full 9 yards, as they say, in terms of intervention. But again, prolonging life, you have to be careful. So if you have a 90-year-old, the question is how much remaining life expectancy they might have. And so if somebody's lived to 90, the likelihood of their living to 93 is about the best they're going to do, unless they're really highly functional. So if somebody is 93 or 90 rather, and they have functional impairments such as a problem with activities of daily living, multiple instrumental activities of daily living, the likelihood of their living beyond 2 to 3 years after is highly unlikely. So that might inform the decision-making capacity or rather the advanced care planning for the family and for that older adult. And then in the middle here, we have maintaining function. And so the idea is that these people are fairly high, what we would call higher functioning levels. and we want to try and maintain their function as best possible. So again, I would use the ADLs, the activities of daily living, and the instrumental activities daily living to guide us in terms of identifying these what I call middle of the road individuals for advanced care planning. And then finally, there's the comfort care individual. These are the people that we know. I mean, the ones that are totally bedbound, have poor quality of life, are highly dependent upon care. Those are typically the people that are almost, in a sense, a no-brainer as to how they would fall into this category of palliative or comfort care. But there may be subtle variations of that. And again, it needs to be put in the context of remaining life expectancy that the individual has. Okay, next slide, please. So part of this is in the context of CPR. So I used to work part-time in the Veterans Hospital in Chicago, and we had a 0% survival rate with CPR. So it really depends on the setting. And you can see here, a dwindling, I don't know, I guess return or capability to resuscitate people as they get older. And it says, these are just wide, all 90-year-olds. But if you have somebody that's like frail, and you try and do CPR on a frail 90-year-old, you've got basically chest fractures, rib fractures, and it's just a miserable deterioration afterwards. And so I think we just have to be respectful of the fact of what the ravages of age do. And again, it's based upon functionality. If they're having a low functionality, as probably is represented by nursing home placement, the survival after CPR is just almost non-existent. Okay, next slide, please. Yeah, and then the other part is the odds of surviving critical care with COVID infections is markedly reduced, with aging. And so the 70, you can look at the bottom row there, that of those individuals that go into critical care units, COVID units, only a third are discharged alive. And a lot of those people have significant functional impairments thereafter. So it's quite the number. And I think this needs to be part of the conversation that, for older adults, do everything up until the point, well, if you get into the, if you're in a COVID unit, then you might want to rethink or change your advanced care directives if you've asked for everything to be done. Okay, next slide. So we just need to distinguish, the medical orders typically reflect, and I think we all know this, the CPR preferences. Doctors from the very beginning of, medical school through, their career will always ask in emergent conditions is what's the code status of the individual. And so that really needs to be up and center. Unfortunately, it's a very, I don't know, to me, it's, I don't know, always troublesome, is there, asking, are they full code or not? But I think equally importantly is that if somebody has the wish of do not resuscitate and let nature take its course, then I think that needs to be honored. That wish needs to be honored. And in some cases, if you do CPR on a patient who has a very explicit do not resuscitate order, in some conditions that could be considered assault and battery. So there are some legal ramifications for not honoring a DNR status. Okay, next slide, please. Yeah, so this just reinforces the fact that, as I gave you the story of 0% survival in the Veterans Hospital with CPR, national studies show that only 3% survival in the nursing home. So, again, you can use this data to help with the conversation with residents and their family, and in the context of filling out the DNR form, You can say, well, this is what the national data shows, and let them digest that and see if that helps inform their decision. Okay, next slide, please. So again, applying CPR relative to the goals of care. So if somebody really wants to stress the prolongation of life, and again, I think a lot of that concept of prolongation of life as we get older is all based upon functionality. And again, just if somebody's highly dependent, then the concept of prolonging life doesn't make a whole lot of sense, because quite honestly, they're getting into that zone of no return that I talked about with comfort care. So again, CPR, in terms of these two groups of people that are moderately functional and those that are low functioning, then typically it should be encouraged not to have CPR. Okay, next slide, please. Oh, and then I just bring up this question about do not hospitalize requests. This is always an issue. This could be an order, a medical order, and it should be. So if that aligns with the patient's care, do everything that you can at the facility, but please don't send me to the hospital. I think that this should be also as part of our armamentarium or options that we can offer residents. Next slide, please. So again, the idea of hospitalization and goals of care. So again, you hospitalize an individual if you want to prolong their life and they meet the criteria, that 94% oxygen or less, they should be, referred to the hospital. But if their goals are to maintain function, the hospitalization may be an option, but again, I would lean towards the comfort care options here, because I think, quite honestly, everything that can be done, I'm a firm believer that the skilled facility can manage older adults very similar to the hospital setting. I mean, the only difference being is intubation. And quite honestly, if a 80-year-old needs to be intubated, that's not a good thing. Okay, next slide, please. Okay, so again, if the family and the patient say that the most important thing is comfort care, there should not be hospitalization, not only for COVID, but for other circumstances too. And certainly if it's a COVID infection, they can be treated in the COVID unit at the facility. And again, if they're that kind of in-betweener, where somebody has reasonable functionality and some level of independence, you can consider the monoclonal, the Regeneron monoclonal antibody cocktail. And then certainly to communicate, what the treatment plan is with the resident and family, certainly tell them that, what is being done and, what the options are. Okay, next slide, please. Yeah, so I think this graph is really, again, just illustrative of what happens. And so on the left side here, you see the functional level. So those could be the added number of ADL deficits, so if you're 80% functionality or 60% functioning, so that could be like, 2 or more ADL deficits. You can see over time that those deficits occur increasingly more so over time, leading to death. And some people can even plot, the loss of functionality in either Alzheimer's patients or, frail older adults along this line. This is a classic line or curve for heart failure, where people get an acute illness that you can see here on the left, and then they dip down in terms of their functionality. They become more bedbound, and then they start to recover, but they just never get back to their point where they were before. And I can tell you that 85% of older adults, those over age 65, if they've had a functional impairment, so they have a deficit in one of their ADLs, 85% of them will have another type of dysfunction or loss of ADL after hospitalization. And so it goes, a steady course downward. So really to think about hospitalization in the context of prolonging life, the question is whether hospitalization will really help accomplish the goal of life prolongation. And again, it needs to be put in the context of how many months of active life expectancy are to be gained. So it's the old question is like, do you want to live as long as possible at all costs, no matter if you're debilitated or not? But I think most people will say, well, if I can maintain a high function and level of independence, then the answer is yes. And I offer this curve to show you, and maybe you could use this with family members to say that this is what the research shows is that if you are already in the facility, you have a deficit in your ADLs, you're going to get another deficit as a result of hospitalization. So again, the steady march towards debility and morbidity. Next slide, please. The other part of advanced care directives is to have good documentation. So a lot of the electronic medical records now have a little signal or a signage at the top of, like, for example, Epic that we use in the clinics will indicate what the advanced care plan is, whether it's been documented or not. But again, this needs to be done in easy access to the staff. If you have a paper record, to have fluorescent labels, for example, if you have DNR status, to have some sort of easily identified measure so the staff know what that preference is. And the second point here is that it may seem obvious about transferring advanced care planning documents, but in my experience, I've written long notes of transfer as the attending physician and as the medical director of the facility that I worked at, and I sent them out with the emergency EM texts. And then I followed up. I called, it's a warm handoff. I call up the emergency room, talk to the physician, and find out that none of those documents ever arrived or they can't find them. So again, even though you give them the documents, you got to make the phone calls, in transfer to provide that information as to what the code status is and what their care plans are. Okay, next slide. Yeah, so this is another part, is that probably should also be on a wristband, if not elsewhere, to include the name and phone number of the durable power of attorney or the healthcare representative for the individual. That's really quite important, and surprisingly and disappointingly gets lost in the transfer process. Next slide, please. So just want to look at the two kinds of advanced care planning. So there's the advanced directives. These are things like, who your healthcare proxy is, what the living will states. And again, those are things like the POLST, that are on the right side with the medical orders that specify what your resuscitation status is, whether you DNR, hospitalize or do not hospitalize, and then whether you want to be DNI, do not intubate. So maybe you want chest compressions, but you do not want to intubate. All those can be put in to the POLST. Some areas of the country use POST, but we use POLST here in the north. Okay, next slide, please. And then we need to align the advanced care with what matters. Really to try and establish clear priorities that I'm encouraging to be based upon the functionality of the older adult. You also want to try to reduce care burden, and I think that's really the second most common reason why people choose advanced care directives, is that they don't want to be a burden on their family. And then also this helps better integrate care. And we try to balance what we know to be health outcomes from our perspective, as well as from the patients on the bottom left there, as to what the patient wants, but also to inform what we can actually do, which is on the right-hand side there. Okay, next slide, please. So just to, we've got all these different formats, and here we have the difference between the POLST, the physician ordered life-sustaining care treatments. So you can see the differences there. So the advanced directives are generally directed for everybody, whereas on the left side there, the POLST, it's for the serious ill patient. So, what happens in the circumstances of a sudden change in health status. And the advanced care initiatives are started by the patient, whereas the POLST should be driven by healthcare professionals. So that's the conversation that you have with the older adult. Okay, next slide, please. And this is just an example. I'm sure everybody has seen the POLST. If not, this is what it looks like. They're pretty much the same from state to state. May have different colors or things, but these were all established quite a while ago as the patient preferences for life-sustaining treatment. And what I think would be recommended, and again, this could be perhaps a PIP, is to maintain a registry of residents with and without the POLST. And then again, the idea being is that after training staff in advanced care planning conversations, and to see if having them interact with the residents, whether you can increase the percent of documented POLST completed forms. Okay, next slide, please. So just to approach older adults and their families, there's different things that we can try to lead into the conversation. I call these icebreakers. Of course, how appropriate to call them icebreakers here in the middle of our polar, winds here and frost. So you can ask, the virus is going around. Have you thought about what it means to you? Or as people turn in health, you can ask them what the goal of care, what's most important to them. And then you can also create, again, these are vignettes or scenarios, that if you needed a ventilator, would you want to go into the intensive care unit? And you can ask the family, do you know what the data is on 80-year-olds that go into the ICU? Next slide, please. So the other question comes up, you want to approach these advanced care planning questions, DNR status, and so forth with somebody that has decisional making capacity. So what are the ingredients for that? Next slide, please. So it turns out that because mostly of cognitive impairment, and I think everybody recognized that up to 2/3 of residents don't have good decisional making capacity, but conversely, there is a percentage, a reasonable percentage of people who can make their own decisions. Next slide, please. So the things that most influence medical treatment decisions, as you can see here at the very bottom, is the patient's understanding of their ability to still be able to communicate with somebody, and also their independence and self-decision-making capacity. And then you can see some of the other qualities that people use in their medical decision-making. And those are not to be a burden on the family, and also the quality of life. So I just highlighted the different areas here that are the most important to individuals as they make their medical decisions. Next slide, please. So there's 4 components to help us understand whether an individual has the ability to make a decision about hospitalization or a procedure. So the first one is, do they understand what's going on? Do they appreciate the consequences of what that decision, what their decision may have. So in other words, do they understand that they may pass away from declining going to the hospital? And then reasoning, that they have an ability to not only understand, but to reason the issue, and then that they can actually express a choice. The problem with the older adult with memory impairment is that they may express a choice and then they forget about it, 30 minutes later because of short-term memory loss. So that's the conundrum with trying to establish decision-making abilities with people with memory impairment. Next slide. So that's the slide presentation on advanced care things. Does anybody have any questions before we go to the case study? You can put those in your chat room if you wish. We'll just take a couple seconds here if anybody has any questions. Okay, so not seeing any questions quite yet. And if you are writing a question, go ahead and put it in there. We'll get to it. So I want to turn to Kelly now and do our case study.
Yeah, absolutely. Thanks, Dr. Juravich. And just to tag on to the presentation that we just went through, I would encourage you all to make sure you have a system in place for verifying that your code status is consistently marked the same in every location. I know most facilities probably have some sort of EMR system and also some sort of paper chart system. So just make sure that that is clearly documented. That can get you in a lot of trouble, and unfortunately I speak from experience. And also the other note I would make is that whenever you're doing training on advanced care planning, make sure you include all staff to at least recognize when it's appropriate to have those conversations. A housekeeper can even be in the room with a resident and they make a comment regarding wanting to be intubated or not. And that housekeeper just needs to be aware enough to pass that information along to the appropriate party who will have those advanced care planning conversations. So just a couple of notes on that. As I mentioned last week, we're going to follow up on our case study that we had done the week previously. We talked about root cause analysis and the screening issues whenever there was an outbreak. So we can go ahead and go to the case study slide, and then we have some poll questions. Okay, so following the outbreak in the facility that we had discussed, the team determined the source of the outbreak was due to screening policies being unclear and unreliable. So the team decided to initiate a performance improvement plan to improve screening policies in order to prevent subsequent outbreaks. Before we go through our slides, we have a poll, I believe, Julie. Awesome. We'll give you a few seconds to look at that. And while this is being completed, if anybody did a root cause analysis after last week's presentation, we would love to hear what you determined on your outbreak. A couple more minutes. We're getting close there, Julie.
Almost halfway.
Awesome. Okay. So what is the first step in developing a PIP following the root cause analysis? Yes, we need to set a goal. Once we determine what our issue is, we need to determine what we want to do about that issue. So we need to set a goal. Which of the following is not necessary for a SMART goal? Correct. Although training is included in most performance improvement projects to some degree, training does not have to be the sole purpose in that goal. And then, which the SMART goal, is this a SMART goal? We will talk about that more in depth, but the answer is false. So for those of you who got that correct, we'll go ahead and go through this. And I do have a question popped up on chat regarding the post. So if anyone has a response to it, asking which departments do you have completing this and when? And is it better offered upon admit during care plan meetings, etc.? And what's worked best for everyone? So if anyone has a response to that, we can definitely do it in chat, or if you want to unmute, we're happy to hear from you as well. Okay, but we'll go ahead and get started while we're waiting on that. I just want to make sure everybody saw the question. All right, so we talked about SMART goals and an example of a SMART goal. As you all know, SMART is an acronym for how this is spelled out. First, your goal needs to be specific and define who will benefit from the goal and what the team wants to accomplish. Once again, we go back to these W questions. I know I bring them up a lot whenever we talk about the 5 attributes, but here's another opportunity to use it. So what do you want to accomplish? Why is the goal important? Who is involved? Where is it located? And which resources or limits are involved? And just to note, this link on the bottom of these slides is to a toolkit provided by CMS. And it's a guide to staff satisfaction, but it includes different quality improvement tools in it. And this is just one of the pieces of that. So just for reference, you can go to the next slide. All goals must be measurable. In order to hold yourself and your team accountable, you need to make sure that it's measurable. So it helps provide direction and allow them to document progress. If you put a system or in place and you're not measuring to see if it's beneficial or not, then it's kind of irrelevant. You need to make sure that it is successful. So how much or how many, how will you know when your project or your plan is accomplished? Next slide. Make sure the goal is attainable and achievable. You don't want to set yourself up for failure. We talk a lot about making sure that whenever you're doing these performance improvement projects, you start out small, bite-sized, in order to really see if it is successful, and then you can move to a bigger group if you want to. So make sure that your goal is attainable and achievable. And you can ask your staff, does this seem like it's reasonable? If you set a goal to deep clean every resident room in a matter of 3 days, is that achievable? No, that's not achievable. So really you're just setting people up for failure. And unfortunately, when you set a goal that's unattainable, it is very discouraging to the staff, and therefore you don't get as much buy-in for the staff to participate whenever you're going for your next project. Okay. Make sure your goal is relevant. Does it seem worthwhile? Is it the right time? If you just got a deficiency on something, then you may put a performance improvement project related to that deficient practice, because that would be the right time, because it is an issue that is arose. And then last but not least, make sure the goal is time bound. This is the reason that last question was false. There wasn't a time frame on that goal. So you provide a timeline in order to track and monitor your progress. So when is it going to be completed? What is our goal? And what can I do today, 6 weeks from now? You know, when you're doing a performance improvement project, you're putting some of your interventions or your steps in place, then you have this needs to be done by this point. Just a way to keep you on track. Right, here are 2 examples of SMART goals. Sorry, trying to look at both screens. In 6 months, which is your time bound, we will decrease nosocomial infections, specific and relevant, by 25%, which is measurable. implementing hand hygiene practices. Now, this doesn't say specifically that you have to have training in here, but if you're going to put new practices in place, you need to make sure that the staff retains the information and understands it. So you would essentially do training, but training is not required to be in the actual goal. It's in response to the poll questions in the very beginning. Another example, in 3 months, we will see 20% reduction in employee shift call-offs by involving staff and scheduling. And so that gives you the details there. Now, when we go to the next slide, we'll look at how we have the performance improvement plan that we're continuing to build off of week over week. Once again, this template Michelle has provided to you all, and I know when we've provided some sample performance improvement plans, they're on this template. So we have our goal in 1 month. We will reduce new COVID outbreaks by 75% by adapting screening policy and procedure. So we determined that screening was the cause of the outbreak because we had a vendor who was asymptomatic and he was exposed and he came in not wearing proper PPE. That's what we determined during our root cause last month. And so we know that we need to do some work on our screening policies and procedures in order to not have that happen again. And Michelle, are you on today? Here. Dr. Juravich, do you have anything you'd like to add?
Yeah, thank you. I think the formation of a PIP needs to be in short increments of time. I think it's really important, and the data has to be ongoing so that you can interpret it and evaluate it on a week-to-week basis so you can see trends. The whole idea of initiating quality improvement are, like I say, little nuggets. They're not to do a real comprehensive, all-encompassing quality improvement project. So it's just small changes, small observations, and they have to be real time so that you're able to act on them. So for example, if you had a fall reduction program and you said, well, in 3 months, we'll see if the falls are reduced by this intervention. You're not going to see much of an impact. It has to be within like a 4-week period that you monitor the intervention to see if it has effect. Now, that said, it's important sometimes to remember that some of the interventions do take a little bit longer. So for example, like is the example I gave in terms of fall reduction, it may take physical therapy in terms of any intervention 4 to 6 weeks before, let's say they have muscle strengthening programs. So let's say you had everybody stand up and sit down 3 times a day, do 10 repetitions of that as a fall reduction intervention. It may take up to 4 weeks before you're going to see that impact. So always align what your expectations are for the intervention with the actual outcome results. I guess that would be my basic commentary. So the other thing was that somebody asked about the about the POLST. So the POLST is a physician order set. So that is in the domain of the provider, but sometimes they need their memories jogged a little bit. And so if you have a proscriptive or a order set that's already created, you can actually put the POLST as part of the order set, as a standing order that where the provider could either check off, do not resuscitate, do not intubate, and so forth. And some facilities will have that as a checkbox mechanism. Others can just leave it open as, you can say POLST status, and then the provider will fill that in. So usually these are an intake. This should be done through like a physician-based. And sometimes if there is communication with the healthcare system, so if you have access to the electronic medical record, you can transfer the POLST documentation from that. But you again need to ask the patient and the family as to whether they still agree with those things, because some people will have filed a POLST 20 years ago, and so it may have changed considerably. Okay, so we can go to the summary here. Next slide, please. So, and just the first point there is exactly what I was saying, that advanced care planning is an ongoing process. So there should be regularly scheduled ACPs done at least on an annual basis, or if there's a change in status. So it's much like the MDS, if you're changing gears, it's a good opportunity to have the advanced care planning. And that could be another PIP, is that with each change in MDS, because of change in status, was an advanced care plan conducted. So that could be a PIP that you can construct. The other one is to train staff in advanced care planning. So our program at University of North Dakota is willing to create small training videos if folks are interested in that, that you can distribute to your staff. And then you can look at whether that ramps up or improves the advanced care planning process. An important issue is to always ask what matters to the resident. There are different tools that we have for asking what matters. My favorite, quite honestly, comes from Stanford Medical Center, and it's called the Conversation Project. It's a letter. So you give this to a letter, and it's a conversation to the family and to the physicians, is that this is what is important in my life. This is what I would like to be done. So if you Google the Conversation Project or the Stanford letter, you'll see what that documentation involves. And then finally, it's just so critical to educate the resident and family about remaining life expectancy. We don't have a crystal ball for sure. And when I've had these conversations with family members, I've sometimes been accused of saying, well, you're not God, what do you know? And I accept the fact that we don't know everything, but we have some pretty good ideas as to what can be futile healthcare versus things that we have some reasonable opportunity to have an impact. And so there are cases where there's 100% certainty that there's nothing more we can do to prolong life. And so making that transition, going from the bridge of intervention to the bridge, crossing the bridge into comfort care, I think is a really important message. Okay, next slide, please. So there's two things about decisional making capacity when you approach older adults about this, or your residents, to ask. You don't want to, just because they're in the nursing home, you don't want to exclude their ability for autonomy and self-decision capacity. But we do have to use observation, and we have specific tools that we can use to determine, and those four different elements are so important to complete. Sometimes the clinical psychologist can help us with that, as well as the providers that are working at your facility. Social work can also be involved in this process in terms of decisional making capacity. And then we want to define the goals in terms of those three categories. Are we really talking about prolonging life? So we want to do everything we can. Or are we trying to just maintain function or provide comfort care? Both of those elements would encourage us and to not use acute care as a intervention. And then finally, to create quality improvement projects around what matters to achieve resident-centered care. So that's, again, one of the, marching orders from CMS is to have patient or resident-centered care. And so if you construct a PIP around what matters, so for example, distribution of the Stanford letter could be a PIP to fine-tune or enhance patient resident-centered care. Okay, next slide. I think so I just wanted to show the resources for these different elements here. So tools for decision-making capacity. If you can make a note of that, these you can download these. The assessment of capacity to consent to treatment is, so it's the ACT. So if you just remember ACCT, you can Google that and get the materials. We can also send them out to you. And I guess we'll actually try and we'll post those on our website. And then there's the more recent McCarthy competency assessment tool. Again, these are checklist kind of items, and they provide stories. They provide vignettes for understanding, reasoning, rationale, and then ability to provide a decision. Okay, and I just as a caveat, these tests are a little they're more cumbersome than doing, for instance, like a mini cog test or doing a St. Louis University mental status test. So everybody put down that doing cognitive testing is an important part of this process, and I agree with that. That in order to determine decisional making capacity, you need to know, what elements in that SLUMS test are deficits. Okay. Yeah, and I would just point out that last storytelling at the end of the SLUMS test about Jack and Jill, is a good way to see if the individual understands and has reasoning capability.